yourself on mute and your camera off right now.
Good morning, everyone. I'm Amy Hewitt, Executive Director for the National Kidney Foundation, serving Northern California, Oregon, and Washington. Thank you so much for joining us for our 52nd Annual Medical Symposium. As we all know, 2020 has been anything but typical. Even in all of its uncertainty, what has been ever present is our creativity and nimbleness. As a result, we do things like take a 52-year tradition and pivot. And while we would prefer to be meeting in person, circumstances have certainly dictated otherwise. So instead, we embrace this virtual opportunity and the fact that we have medical professionals joining us from all parts of the US and even some abroad. So welcome all, and thank you for being here. Before we get started, we have some general hop-in housekeeping items to keep in mind. And I would like to welcome NKF Senior Vice President, Scientific Operations, Jessica Joseph, to share more.
Thanks so much, Amy. Hi, everyone. Welcome. So happy to have you here. If you guys can hear me okay and see me okay, you're already in great shape. The first thing I want to make sure you guys are utilizing the chat functionality in a great way. So please make sure you're toggled over to the stage chat. If you guys are in the stage chat, can you all just type hello and maybe type where you're from, what city, what state you're from? That would be great. Would love to see that. And just so you know, that stage chat, this is where you're going to be conversing and asking questions to the speakers throughout the day. So all of your questions for your speakers are going to be in the stage chat area. We'll make sure that we have time for Q&A after every single session. So make sure. Awesome. We have people from California, of course. Some people from Houston, Texas. Awesome. Arizona. So happy to see all of you. Brooklyn, New York. Hey. Awesome. If you toggle over to the event chat, that is the area where we'll be kind of posting some information about when the expo is going live. You'll see that event chat function no matter what area of Hop-In you're in. And then on your left-hand side, on the left-hand toolbar, you guys probably have already figured this out, but you have all of these icons of reception, stage, help desk, networking, and expo. Please feel free to hop through all of those throughout the day. The help desk, we are here to help you. If you go to that help desk area, there'll be an NKF staff person on screen to help answer any questions you guys might have. If you have a tech issue, if you have questions about CEUs, about the program schedule, we're here to help you. So please feel free to go to that help desk area. There are some breaks throughout the day. There's a networking and an expo break. So feel free to check out those areas. The networking is kind of like a one-on-one speed networking, or like speed dating, we would call it. But it's a great way to meet some of your fellow attendees who are here, and you can connect with people. The other cool feature, you can also directly chat and video chat with any individuals throughout the conference. If you look to your right-hand screen where that chat area is, you'll see chat, you'll see polls, and you'll see people. If you click on people, you're going to see a whole list of all of the attendees that are registered for the event. You can click on an individual attendee, and you can actually send them a direct message and say, hey, Amy, it's great to see you. Would you maybe want a video chat during our lunch break today? Let's plan to chat at noon. And you can actually click on that invite to a video call, and there'll be a link there, and you guys can chat one-on-one. It'll send you guys into a little meeting room, just the two of you. So that's pretty cool. There are going to be some polls for some of the sessions later in the afternoon, and you'll see that up above as well. So we'll guide you over to that little poll area, and you'll see the poll question pop up there. And then also, please be sure to check out the exhibits, that exhibit area. If you click on Expo on the left-hand side, you'll see a whole listing of all of the exhibitors. You can go visit all of their booths. Some of them will have live sessions. You can actually hop on screen with them. To do so, if they are on a live screen, you'll see right above you or the individual speaking on screen, there's a little share audio and video button. It's going to be in orange. You'll also see that in the help desk area. You can click on that, and you'll be able to be on screen and talking with your exhibitors and the representatives. So I think I covered everything. If you have any questions, again, please feel free. You can type them in the stage or the event chat. We'll help you. You can hop over to the help desk at any time. And we really hope you enjoy the conference today. And I will turn it back over to Amy.
Thank you. Thank you, Jessica. And many thanks to you and your team for helping us to create today's virtual environment. We would also like to share our deepest gratitude to the individuals and organizations who have helped make today's program possible. I want to thank our speakers. They volunteered their time and expertise. I also want to thank the planning committee led by Dr. C.G. Zhang. It is our pleasure to work with such a dedicated group of your peers. And of course, our very own Patty McCormick, Program Director, and Celine Coe, Program Manager. And finally, a heartfelt thank you to our sponsors. Our gold sponsors, Amgen, CareDx, Fresenius Medical Care Renal Pharmaceuticals, and Satellite Healthcare. Our silver sponsors, AstraZeneca, Pentec Health, Relipsa, and Sanofi Genzyme. Including today's sponsors, we have a total of 18 exhibitors, which is really amazing. Together, we all serve our kidney community, so thank you very much. To keep things interesting and to keep us learning throughout the day, we have crafted a scavenger hunt, which I've seen many of you are already participating in. All you need to do is visit at least 8 of our 18 booths, jot down what you learn on your scorecard, and submit the form. And if simply learning wasn't enough of a motivator, you also have the chance at an Apple Watch Series 6 along with other prizes. We've included full scavenger hunt instructions in your virtual goodie bag, along with other great resources. You can also learn by following the link in the chat. Now it is my pleasure to introduce our program chair, Dr. C.G. Zhang. C.G.'s vision and energy has been the key to the committee's work, and we're extremely grateful. C.G., thank you, and take it away.
Thank you very much, Amy. Welcome, everyone. This is our 52nd symposium. And it's a great success already. We have almost 400 people attend this symposium. This year's theme is 2020 and beyond. We hope that despite all the things going on, COVID, we are going to overcome all these challenges and we'll emerge very strong, very motivated, and very innovative. So that leads to our first speaker, Dr. Leslie Wong. I can spend an hour to introduce him, but I'm just going to say he is my best friend and thank him for joining. Leslie, it's your turn.
Thank you very much, CJ. So let me just share my screen here. Well, thank you very much for the opportunity to speak at the NKF annual symposium. It's been actually about 10 years since I've been, been a participant, and so I'm really thankful to be part of it again. I'm living actually on kind of in the Midwest, East Coast now, but again, the Northern California NKF and all the great caregivers out there are near and dear to my heart. So with that, I was asked to speak about telemedicine and nephrology and how the pandemic will accelerate innovation in how we take care of patients. I wanted to, again, really acknowledge Dr. Zhang's, not only his tireless efforts to promote, better kidney care, but just to kind of give him a shout out. I've known CJ now for about a decade, and really got to work with him closely when I was at Satellite. He's been just a great collaborator over the years, and a thought partner in terms of how we as nephrology, caregivers, not just physicians, but our nurses, our dietitians, our social workers, and our patients, how we can push the envelope and make lives better for everyone involved. You won't find a more ardent supporter of home in Dr. Zhang, but I also share that he and I are both home Asian cuisine aficionados, so we don't miss the opportunity to do that when we're together. So just some disclosures here that I won't read through, except just to share that while I wear a variety of hats, all the views and opinions shared today represent my own. And so we have 3 big goals today. The first is really to articulate the major changes and impact that telehealth has had on nephrology in the context of this ongoing pandemic that has really touched all of us in a pretty profound way and touched our society. I want to provide an overview of how traditional kidney care and how we thought about taking care of patients with kidney disease has really been disrupted, and disrupted in a really significant way by COVID-19. And then we'll take some time to explore not only the current but the future uses and utility for telehealth that I think the pandemic, if there's any silver lining here, has really shown us. So, when you're asked to talk about innovation and the future of telemedicine, I couldn't think of a more appropriate example than telemedicine in outer space. This is actually a case that was published in the New England Journal of Medicine. And it really struck home for me because as I was kind of doing a little bit of research, I noticed that Dr. Stefan Moll, he's originally a physician from Germany, but he's been on faculty at the University of North Carolina for many, many years now. And in fact, he was one of my teachers and mentors as I was a resident. So what happened was that the astronauts in the International Space Station, one of them was having some issues with their neck, and I think they had an ultrasound on board, and they discovered that the astronaut actually had an acute deep venous thrombosis in their internal jugular vein. Well, obviously, when you're miles and miles and miles above the surface of the Earth in outer space, it's pretty hard to drop in to see your physician. So the scientists and physicians at NASA actually contacted Dr. Moll, and they basically did telemedicine management of acute venous thrombosis in space. And I think I included this quote here because it's actually pretty it was pretty interesting because as he and the NASA scientists and doctors were managing this, he would get these phone calls at home, and so his wife picked up the phone and said, "Hey, listen, this is your telemedicine call from space." And what Dr. Moll commented on was that the reception was actually better than when he calls long distance back to his family in Germany. So I think that's a great story and anecdote just to set the stage for the presentation about telehealth. Now, I think one of the things is that the terms telehealth and telemedicine often get confused, and and I'm guilty of using them interchangeably, and you'll read a lot of stuff, but in general, telehealth is the use of electronic information and communications to do any type of remote healthcare. That's inclusive of education, public health activities, or even health administration. So what we're doing today is technically telehealth. Telemedicine is more specifically about when a provider provides a remote clinical service, and again, it's a licensed provider. So again, I mean, just to be aware that there is a little bit of a nuance there, but for all intents and purposes, we use these fairly interchangeably. Now, with that, again, this is not a test, but as we look at how technology has evolved and changed over just in a very, very quick period of time, we grew up with a telephone and a television. That was basically it, and maybe a radio. But now we've got all types of mobile devices that allow us to communicate not only locally but internationally, and as you saw, even into outer space. I think some people, when they try to think about the definition of telehealth, they say, well, listen, this is all great, but can I bill for it, right? So I think one of the things that I'm going to try to do is give you some background about what services are actually reimbursed and why they're reimbursed and how things have changed with COVID. There are two definitions, though, I think on this slide that are important to know. There's something called synchronous telehealth and asynchronous telehealth. And what synchronous telehealth is that when you're communicating with a real live human being real time, and that's either face to face through audio, video, or sometimes it's even just audio. But again, it's where the other person is real time. There's a real time conversation. Asynchronous, this is something where there's a saved image or there's something that's not real time. And we'll talk about it shortly, but that if you imagine if the patient has a secure portal through their EHR, like MyChart, they send you a message and things like that, and you read that 3 hours later. Well, that's asynchronous. So let's then talk about telemedicine before COVID-19, because we know that understanding where all these definitions and where all the regulations came from is important to really apply to where we go in the future. Now, telehealth, okay, was developed originally for underserved areas, right, where people didn't have access, easy access to health practitioners. And so another important definition is this concept of the originating site. So this is the originating site is where the patient is located when they receive some type of telehealth service. Now, as you look at the map on the right, it actually shows California, and so anything that's in green is what's considered a metropolitan statistical area. Now, if you know California geography, there's not much of California except the high Sierra Nevadas that isn't a metropolitan statistical area. So basically, in a lot of parts in the country, it was really hard to qualify for telehealth services. The other ways you could qualify for this is that you were in a health profession shortage area, and those are typically in rural areas, or you were part of a federal telehealth demonstration project. So telehealth has been around for a while, but we weren't using it at scale because of these kind of geographic restrictions. Now, I think we're really strong on patient-centered care. And when you start thinking about the originating site, this is where the patient is located. But if you look at the localities on the left, we would hope that none of our patients actually are there unless there's a reason, right? Like they're in a skilled nursing facility because they're getting rehab, et cetera, et cetera. But the punchline here is that Medicare did not look at the patient's home as the originating site. So, again, ironically, a patient would need to get a ride to their telehealth appointment, which in many ways kind of defeats the purpose. Now, the distance site, okay, that's where we, as practitioners, would be located. And the slide here shows the licensed practitioners who are authorized, if they were in a qualified area, to deliver a telemedicine or telehealth service, right? And it's really clear that that practitioner has to be at a different site than the patient. Now, you think about I just think about the interactions that I'm having with my teenage kids who are all at home now, and we're actually having, chats or texts like from the living room to the dining room. So that actually doesn't work. When you're doing telemedicine, you actually have to be at a completely different site. So how does that, or how did that really translate to us as kidney care professionals? Well, telemedicine pre-COVID actually did allow, again, in those rural, areas, health profession shortage areas outside of the metropolitan regions, right? They did allow us to take care of dialysis patients, but it was very, very, very restricted. Okay, so you had to be you could be a dialysis unit. That is, you could see a hemodialysis patient, but they had to be at what they call a critical access hospital, right? And those are typically in rural areas, but they could not be freestanding. So unless it was a hospital-based unit, even if you were in a rural area, but you were a freestanding unit, like many of you in the audience work at, those are excluded. But what happened was that in 2018, Congress passed the Bipartisan Budget Act, okay? And this became effective January 1 of 2019. And this may be jogging some of your memory, right? Because it was like, hold on a second, we're going to be doing telemedicine for home, right? So in fact, you could still do it in center, but it was still restricted. But the originating site restrictions were loosened to include dialysis facilities that provided home dialysis, and also the homes of home dialysis patients, right? So the originating site could be the patient's home, and the distant site could be the home dialysis unit. So this allowed us to deliver care not only for in-center patients in this restricted definition, but also to have patients at home not necessarily have to come into clinic all the time. Now, there were some restrictions here that were a bit controversial and did spark some response from not only nephrology, but also patient organizations, right? So it said, well, listen, if you're going to do telemedicine for dialysis, you have to still have a monthly hands-on visit to look at the vascular access. Okay, of course that didn't apply to PD patients, so that was an issue there. But one thing is that you still needed to have audio and visual. So a telephone encounter wouldn't count, but if you had some type of equipment, right, which again, many dialysis facilities and units don't have that equipment, the patients don't have it, you needed to see them real time to do the interaction. The other thing was that home patients would still need to be seen face to face for the first 3 months. Okay, if they're so including their training, but then could be seen quarterly thereafter, face to face. So if this is all kind of confusing or you have questions, we should have some time later. But again, this is what we were living with pre-COVID. And if you spent more than a few hours in a dialysis facility, you know that we are one of the most highly regulated professions, right, in all of healthcare. So there are all these rules, and they're different if patients are Medicare. They may be different if they're Medicaid, and I think in California you have Medi-Cal, right, and between private payers and employer health plans. Suffice to say, while the government, has regulations on telehealth at the federal level, it's really, really important to understand state-specific telehealth laws and guidance. And at the end of the presentation, I actually have that website for you to look at. But suffice to say, there were little differences between all these different payers, which made the implementation of telehealth even more challenging. Then, I think we heard some stuff at the end of 2019 and certainly the beginning of 2020, the world changed. And so I'm going to shift gears after giving you kind of a background about where we were in telehealth and maybe helping us understand why we weren't using it that much, to what happened during the pandemic and how we actually had license to break all the rules. So, this is a very sobering slide, but I think it's worthy of reviewing. With all of what we've seen and what's still going on in our country, it really hits home for us as kidney people, right? That the first reported coronavirus death in the United States was a dialysis patient. And not just a dialysis patient, but a dialysis patient living in a nursing home. So very, the most vulnerable of the vulnerable. And so, immediately, there was a lot of concern, and many of us we're continuing to live through this about, the vulnerability of our dialysis patients and patients with kidney disease, and we as caregivers to that. And so, in response to this, there were these, kind of unprecedented changes that came out of the federal government in terms of waivers that allowed a more liberal use of telehealth, but also expanded benefits. And also what is important to note, a notification that federal and state officials should have discretion at enforcing, laws and regulations that previously existed that limited the use of telehealth. Right. So this is something that, again, I don't know if we'll ever experience this again, but this is basically the federal government saying, well, listen, we had all these rules. Now, you get a pass. Now, why is that so important? Well, because, it's clear that the utility of telehealth could not be more relevant than during the ongoing pandemic. Obviously, as you see this front page article from the Chronicle, and now what we may be seeing it in states again, how do you get healthcare when you have a stay-at-home order? How do you protect patients who are, need transportation, right, or rely on public transportation? And what happens when someone's quarantined or they're actually ill? You don't want patients moving around in public, right? Now, in efforts to protect the community, think about the utility of telehealth and limiting patient-to-patient contact. How many times when you go to the doctor's office, you're sitting in a room with a bunch of other people, right? You can't do that during a pandemic. And particularly with the fact that some patients and their caregivers might be actually asymptomatic at first. How do you protect us as healthcare workers and avoid facility outbreaks, which again is something that any of us in dialysis have been very, very fearful of. And so as an example, of things that were loosened by the COVID waivers. You could actually do telehealth now in the office, right? In the doctor's office, whether you lived in a rural area or not. You could also even do them in the hospital, requiring, again, synchronous encounters. That is, you had to have real-time, eye-to-eye, visual and audio capability. But you could also do these things called virtual check-ins. Okay, and these are things that include not only video but telephone, patient portal. These are things that may be synchronous or asynchronous. So again, this is meant to be like a short visit to prevent the patient from having to go in to actually do a full visit or see someone. Or some of these e-visits, which, if you think about it, it's kind of like secure chat, right? The patient has a question or a concern or symptoms, and they can do this, and they can send that in through a portal, and then a nurse practitioner or nurse or a doctor can respond. So this is all new for us. And so what are some really key changes that happen then? Well, remember I talked about this requirement that for dialysis patients, you actually had to have, even if you did telehealth for their monthly visit, you still had to have a monthly visit and physically examine their vascular access. Well, the waiver said you didn't have to do that anymore. They still required for home dialysis patients, they have to be seen face-to-face for the first 3 months. Okay, but then after that, and all of the dialysis patients could be, including hemo, could be seen every quarter, right? There's some other things listed here, I think, that are important. Paying for telephone visits, waiving requirements for state licensure. That means that I, living in Ohio, could actually perform and deliver telehealth in the state of Pennsylvania if the state actually allows that, right? And then some other things that when you start talking about Stark laws, and when the government is saying we're not going to enforce some of these Stark laws, it's a big deal. Now, this discretionary enforcement of HIPAA, and I think it's worthy of mention because, HIPAA is such a important thing for healthcare providers and how we deliver telehealth, particularly in the past, right? We were limited because it's like, look, not everyone has a HIPAA compliant telehealth platform. But again, you have the federal government saying, look, we're not going to actually impose penalties if you don't have all this stuff kind of locked down. But we do recognize that some of the platforms that are commercially available do meet HIPAA compliant standards, okay? Now, obviously, I think if you were to poll the audience here, you probably all use different platforms. I say every day, I have to juggle between 3 or 4 virtual platforms. But I think as we've looked at this, many health systems have tried to either contract with a licensed vendor that's HIPAA compliant, or to use in a controlled manner some type of commercial platform, but with some controls. There are some things that are clearly banned. So things like TikTok, Facebook Live, and whatnot. And if you do want to go to jail, and what the icon on the left is, there again, this doesn't replace good judgment and good ethics in terms of when you're performing a telehealth visit. But there are some things like Apple FaceTime, Zoom, Skype, things like that could be used, but again, with a caveat that you still need to talk, you still need to get consent from patients when you're doing the visit, but you also need to let them know that there might be some security issues when you're not using an official platform. So what are some disadvantages then for patients? Well, clearly, if we could see patients face to face for a lot of things, we'd prefer that. And patients don't always have good internet, right? I mean, we struggle with that a lot. And some patients just would prefer to see someone. But on the physician side, right, there again, some of the things that we pick up on, you just can't pick up on all of the cues when you're not actually laying hands on someone. Particularly if it's a patient that you don't know, that you're not familiar with. I think the one thing, if you work in a dialysis center, that has been brought up, and I think is a real issue, is that, we understand we want to limit contact between patients and physicians, and we want to protect folks. But one fear that a dialysis facility have raised is that, listen, my docs and nurse practitioners aren't around anymore, but yet we're here. So it's like, you kind of lose that teamwork, you lose that connectivity. So that's, I think, something that's really important for us to always be mindful of moving forward. So I can share with you what we did locally at Cleveland Clinic. Prior to the pandemic, only 2% of our outpatient clinic visits were done by telemedicine. And in fact, we had a telemedicine platform, I think about 3 or 4 years ago. It didn't really work because even my own patients, we would try to encourage people to do a distance health visit, but they'd be like, Dr. Wong, why should I pay and do this telehealth visit when I can just drive there and see you face to face? Well, clearly the game changed, right? And rapidly, with, I think, a very, again, a very concerted and organized effort, the whole clinic shifted all of its outpatient from face-to-face from 2% to 75% telemedicine in a short period of time. And I think some important call-outs. The existing platform that we were using was completely overwhelmed. So the administration actually said, well, listen, for a temporary time, as I've just mentioned, we're going to let you use FaceTime and Google Duo. I mean, you would have never thought this would have happened a year ago, right? Just for pragmatic purposes, because we have to be able to reach patients. But I think anytime that you do something like this that's so different, having the support, having a playbook is really, really critical. And again, I worked on part of this because the nuances of all the stuff that I've shown you, like kind of all the stuff that we learned that we couldn't do, all of a sudden we could do, but we still have to be within, we still have to follow some guidelines to be able to get reimbursed, but also to deliver it in a way that's HIPAA compliant, and even if they're not going to enforce it temporarily. And so here I think is just an overview of how telemedicine has impacted the practice of nephrology. So in the hospital, right, you could actually do a video visit. And again, the remote stroke teams and remote ICUs have been doing this for a while, but very, very new for nephrologists. We actually had this, and some of our endocrine endocrine colleagues were doing this at some of the hospitals. Not a huge amount of take on because we didn't have as big of a surge in Ohio as some other places, but we were prepared to do that. In the office, a variety of different ways that now patients could be seen, either doing the synchronous, right? It's the telemedicine like we think about it, or then going through telephone encounters or e-consults. And then as you know, if you work in a dialysis unit, and which I've gone through, being able to do visits remotely with patients while they're on the machine or they're training or they're at home. Okay. Now, how long will these last? The declaration of a public health emergency was made in early January 2020. I believe that was actually, someone can fact check me at the end of this, but I believe that was renewed. So it's certainly still ongoing, and we don't know when this was going to end. So for all intents and purposes, this is where we're at right now. So I want to then talk about then how have all these factors and this complete 180 in terms of how we think about and deliver telemedicine, how this happens so quickly. How will this accelerate innovation? And is this going to go away, or is it the future? And I actually think it's not going to go away. And I think it is, in essence, we've put the accelerator on where we're going to be, 5-10 years from now. And so, if you think about it, healthcare has been disrupted by the pandemic, but telehealth has really disrupted healthcare as well. And so when you think about, you should always listen to your mother. And if the mother of invention is giving us some strong signals, we need to take that into account as we start looking towards the future. So I've heard early on in the pandemic, I heard a lot of I heard a lot of comments like, this is just let's not get too much into telehealth because it's just going to go away. Just wait until Medicare just pulls it away and we don't get paid for it and no one's going to, it's just going to kind of disappear. Well, I don't think that that's actually going to happen. Okay. When you look at forecasting for telehealth, even before the pandemic, there were a lot of projections that the annual growth of telehealth was going to continue to accelerate over time. In large part because, remember, when we talked about, like, it's not just Medicare, right? It's private payers and different programs and technology were already being set up to deliver healthcare in a distance way, right? So the patient doesn't have to actually come in, or if you don't have access to a specialist or resources, that you could do things, right? Even like surgeries, right? Robotically, like from far away. So what we see now is that, look, are we actually seeing was the rocket pack attached to telehealth, and is it just going to continue to climb? And certainly, I would say it's going. The slope is higher than what was originally projected. And so, stepping back though, let's look at and again, there's a lot of papers that are out there. They're not like the 100% best quality, but I think it was useful for me to look and see, like, what research were people doing before the pandemic about preferences. So the study on the left was a cross-sectional survey, a survey that they did out of Chicago, I believe. And what they did was that they just kind of grabbed people off the street and said, hey, well, listen, like, what do you think of telemedicine versus seeing your doctor? And there's clearly a break here, right? So the younger you were, right, and likely more savvy with technology, the more likely we're to say, well, listen, I actually think telemedicine is a better deal, or more preferable for me. And again, the older cohort said, the majority of them still preferred face-to-face visits. But it's interesting when you look at the study on the right, where researchers looked at using a wearable technology, right? We're talking about, like, we're not talking about the Apple Watch that one of you will win, but something like that, like monitoring using telemedicine for people with Parkinson's, right? People that had special health needs actually rated telehealth higher. So again, it gives you kind of a window, like, when there's a need and telehealth can meet the need, people actually like it, and it works. So what's the future then of telehealth in the U.S. and across the globe? I believe that that my slides are going to be available after this talk, but there's been a lot of this kind of economic forecasting, these CAGR, these compound annual growth rates, and you saw that the slide, the earlier slide about how technology was already driving telemedicine and remote health before this. I think in the context of the study that I showed you about the Parkinson's patients, right, we have to realize that there are 157 million Americans with chronic diseases in this country, and 40 million of them have some type of related limitation in their ability to perform their usual daily activities, whether that's dressing and feeding themselves or just getting around in the community, right? So again, you can start to see, like, how as the country ages, right, and our demographics change and our technology gets better and our needs change, right, that telehealth, it's like that demographic is going to shift. So that earlier study where folks were older folks are like, I don't really think I need to opt into technology. I share with you here that star. So what that star represents, that is when I'm going to hit 65. And you bet your bottom dollar, when I'm 65, I'm going to be using telehealth, because that's what I'm actually doing right now. So, it's still, though, I think it's incumbent upon us to consider some of the real life barriers here, okay? Because as optimistic as we can be about the use of telehealth for seniors and people with chronic diseases like our kidney patients, there's still tons of barriers, right? More than just bandwidth. I do think, though, that over time, much as the mobile phones were things that you had to carry around a battery pack 15 or 20 years ago, and now they're so small and compact, technology keeps getting better and better. And so it's the people that use it, and as medical professionals, as they continue to gain expertise and we continue to see, like, all these patterns, again, it helps us develop the better technology for the future. And again, again, for folks like Dr. Zhang and colleagues at Kaiser, this was a study they published in New England Journal of Medicine a couple of years ago. But just looking at, we used to think of telemedicine as being on a desktop, but in fact, most of telemedicine is actually done by smartphones. And so I think that trend is probably going to continue. Now, I talked about how skeptical some of my colleagues sounded when all this started, right? Because maybe their previous maybe had no, either the previous experience was very limited or they had no experience in telehealth. This is again, this is not an advertisement. This is just a group of physicians that I work with in one of my jobs. And these are practicing, these are practice leaders out. One, Mark Belts is in Iowa, and Darren Glenn is in Richmond, Virginia. But we actually we interviewed both of them, and it was really insightful and educational, because you heard these doctors, these nephrologists, who had practiced for 15, 20 years, doing it the old-fashioned way, and just hearing the excitement and the enthusiasm, not just for themselves, but for their patients, right? Like, hey, listen, we actually tried it, and we see how this could work, right? So again, kind of, I think, that's the tipping point, right? When you see the benefit for your patients and you're able to advocate for them. So, there are there's a ton of literature out there in terms of nephrologist experience during the pandemic. I just wanted to highlight this article because I think it's a good way that I thought that we could leverage some of the existing technology we have now with some of these waivers and things that I think were made available to us and are available to us. So this is an experience out of New York City, where the nephrologists there were saying, well, listen, we have home dialysis, right? Which, in some ways is a benefit for patients to reduce, their need to go in center and transport and, have to do public transportation. New York City, right? People typically don't drive, right? They take a subway or they take, or some other transportation. But what they were able to do is that they were able to use Zoom, right? And again, if you looked at my earlier slide, Zoom is actually one of these kind of more compliant platforms, although was never designed to be a telehealth platform, right? They were able to do that, and they were able to use some of their existing technology, which, again, these images are from Baxter and NextStage, but the device manufacturers were already starting to incorporate distance health, kind of telehealth into their platforms, right? So you could do remote monitoring. So you could see what the patients, are doing at home. The patients have an iPad at home where they're putting in, treatment information. So they were able to actually kind of weave all this together. And then they reported they were able to do these things. Now, again, the benefits, right? Reduced staff exposure. They were, the doctor didn't have to be at the unit to do their clinic visit. And I think importantly, it allowed the family and the whole care team to actually participate. So, and I experienced this myself as I do my home dialysis visits remotely, actually seeing, I've got my nurse, my dietitian, the social worker, and on the other side, it might be the patient, but it might be their daughter or their mother, or we're seeing everyone for the first time, and patients reported immense satisfaction. Of course, there are hurdles that we haven't been able to overcome yet, like how do you do your labs and your meds? When someone's actually having an access issue, seeing the venous pressures is one thing, but being able to examine it is another. So again, there are some integration issues there, but I think, again, when people are given a challenge and there's technology out there, it just shows how a lot of resourcefulness can lead to good patient care. Now, this it's just a kind of a collage of different things that I've experienced, right? We know National Kidney Foundation actually went virtual. That was a huge deal, right? So again, kudos to NKF for actually leading the virtual meeting, drive in nephrology. But as you see, whether you're talking about ASN Kidney Week, which was completely virtual. I actually participated in the Greater New York Hospital Association webinar series on treating AKI and COVID. And then again, with a lot of great colleagues from across the country, there's unprecedented interest in telehealth. And I think that's something that's not going to, we're not going to be able to turn that off. And so when you look at then, accountable care and value-based care, a lot of the things that are being thrown around in terms of where healthcare is going, right? Even in 2018, right? If you were a two-sided accountable care organization, you were allowed to use telehealth. You know, and all these services I have here listed, and for the physicians in the audience, right? These are all eligible for telehealth in the CMMI voluntary kidney models. And so on the right, when you start looking then at the value-based payment continuum, really what you're saying is that in the old-fashioned world, right, you had to see a patient like face-to-face to get reimbursed, and that's the kind of model that supported your care. But now as you go towards accountable care, it doesn't matter if you see the patient face-to-face or you do it virtually, as long as you're able to communicate and deliver the right care, that's what actually matters, not only from an economic standpoint, but from the patient standpoint. So we're clearly not meeting the needs of CKD patients the old-fashioned way. So I'm shifting gears a little bit. When you look, and this is from NHANES data from USRDS, but suffice to say, you see a bunch of stuff on the left. That's all the early stage CKD patients, right? And you see, you know, relatively fewer in the later stages. Now, the reason that's important is that if we are relying on face-to-face visits in order to take care of the people in the earlier stages, right, we just don't have enough people, doctors, nurse practitioners, or nurses, to do all that care. And that's really critical, because if we don't intervene upstream, we can't actually slow and prevent kidney failure, which is actually what we want to do, not just treat it. And when you look at the responses, not just from the patients, but from the PCPs, they're not totally happy, because it's hard for them sometimes to get patients to come in to see us. So as we start thinking about changing the lens of healthcare delivery, right, and we've talked a lot about the Advancing American Kidney Health Act, right, in terms of like home dialysis and transplant, but really the patient-centric reasons that we're promoting this are we want to promote flexibility of lifestyle for our patients. We want them to stay employed, and we want healthcare to be more convenient, right? And all these things on the left should really resonate with us as patient-centric providers. And so as we think about the pandemic, innovation, telehealth, and the shift from volume to value, I want to clarify a misconception. People think that because we're going away from fee-for-service that we're not going to have to see the patients that much. That's actually not true, okay? What we want to do is move away from what we call high-touch, high-cost care, right? So if our model is sending patients to the emergency room, right, or taking care of them in the hospital because we can't do it any other way, that's the most expensive and the least satisfying way to take care of a patient. On the other hand, what we're trying to do, we try to promote this in our ACO, which I'm involved in, is how do you do low touch, low cost care? In fact, how do you increase utilization of lower cost care that's more effective? Whether it's through remote monitoring, using artificial intelligence and predictive algorithms, and really having the patient being able, through those smartphones, right? The Kaiser data shows you, right? Patients are able to use smartphones to interface with us and not have to wait for an appointment to have their concerns addressed and to communicate back and forth with us. So, health policy is going to support telehealth, and I'll tell you why. When you look at the reports from, and this is from New England Journal of Medicine and from the American Hospital Association, right? The big healthcare systems like mine, we're crippled, right? We're hit with the pandemic because people couldn't go to the hospital, right? We've been criticized for not doing healthcare, but sick care. And so the great barrier of actually getting people into the high touch, high cost model translated into the bottom line. The bottom line was $323 billion of losses for hospitals this year, right? So do you think that makes hospital executives think that, something, the old-fashioned way is probably not as secure as we thought it was? And in fact, today, I got an email from Cleveland Clinic saying we're starting to cut back again on outpatient surgeries because we're actually seeing a surge. So telehealth is a lever to drive policy reform because payers, and I think society, needs to support utilization that drives value. And I think the pandemic not only has illustrated the benefits of telehealth, but also exposed a lot of health policy inequity that we need to address. So, I'm going to close here by, I promised I would share with you this, but California actually has a really nice telehealth resource center. It was all I could do not to like take some of their slides. But again, their slides are actually available, but I think can answer a lot of questions that you might have at the local level about, what can I actually get reimbursed for? How to, what license do I need or not need to be able to do this? And I think for those of you who spend a lot of time in taking care of patients on dialysis, there's actually a toolkit that you're able to use and access. And again, the links are here, and that has a lot of information that's relevant to to your patient care. So with that, as we look to the future, Dr. Mall, I actually contacted him. I was so happy to hear his story. He sent me this picture, and I think it's really emblematic of where we're going to go, right? The giant leaps start here, and I think we've taken that leap. So with that, thank you very much to NKF and CJ, and for all of you for inviting me to be here. And I'll take any questions.
Thank you, Leslie. That was a wonderful, wonderful talk, and I've learned so much. Anybody has any question? Please put in the chat box. While we are waiting for the question in the chat box, just share some of my personal experience. I love telehealth, and my patients love telehealth. Before the pandemic, I was doing about maybe 25% of telehealth. After the pandemic, I almost get to 90, 95%. Sometimes I'm doing 100% of that. I think it's a win process for everybody. Number one, it's a win for patient. Number two, it's a win for physicians. You take care of your patients. Number three, it's good for environment. Patient doesn't have to drive and spend all the gas on the road. And it's a win for the society. It's a win for a healthcare system. It's going to be here. It's going to stay. Whatever the healthcare system take advantage of this, it's going to do great for our patient and for the society.
Yeah. So, there are a couple of questions there. I think one of them, it's the semantics of telehealth versus telemedicine. Both could be right in terms of if you see a patient on dialysis or in your clinic. Telehealth is the umbrella, kind of like it's a sports car. Telemedicine it's a Corvette. I think, though, I did mention something about healthcare inequities, and I think one of the participants really voiced an important question. Access to telehealth is much like access to healthcare and other necessary resources, not equal across the board. So, we mentioned kind of the situation that patients in long-term care, right? That was a first COVID patient, but also I think patients that are in where there are socioeconomic disparities and we have challenges for the determinants of health. We're going to need to look at policy interventions and other local things that can ensure they have the same access to that care, because their needs are no different. In fact, they might even be greater because of some of the barriers. So that I appreciate that question.
So Dr. Schiller has a question is, can you talk about your personal experience with telehealth in ESRD care, both for home and in-center patients?
Yeah, it's been really nice for the patients. I'll say that, there are times where I don't have a clinic scheduled, but something comes up and, I have a 30-minute break and we can do a 15-minute telehealth visit. I do think that has been nice. I do think the challenge, though, is the burden on staff and patients if they're not used to it, or if there are any technical glitches. I don't think that can be underemphasized. I look at my social worker, my dialysis nurses, and the patients, and sometimes when things go great, it's great. But when they struggle, whether it's a bandwidth issue or they can't get into the right meeting, it really puts a lot of burden on. So again, I don't want to portray telehealth as being perfect. It's by far from perfect, but I think as we use it, I think patients demand a better experience. I think that will help drive the technology and drive our workflows towards that.
Dr. Law has a comment on the nephrology fellow will need to be revamped. Training for nephrology fellow would need to be revamped to ensure they will continue to improve. And there is a question about for kidney transplant patient, and there's a question on reimbursement. Let me just comment on reimbursement. At Kaiser Permanente, I don't have to worry about reimbursement. I just take care of my patient.
Well, I think actually, CJ, I know we're running short here, but I think this is where telehealth really aligns really closely with the idea of value-based healthcare, right? So if you take responsibility for a patient's health across the continuum, then it doesn't matter if you see them face-to-face or you do it remotely, as long as you're providing high-quality care and and meeting the patient's needs and going from there. So. The challenge for us is to make that experience as good, not only for the patient, but for the caregiver, so that we're communicating and operating effectively.
Great. There's a question on, is telemedicine acceptable to do HMPs?
I'll take that at the history and physical. That again, it's a broad term, but according to the Medicare waivers, telemedicine can be used for initial visits, whether in inpatient or outpatient settings, as long as you meet, again, certain requirements. It does have to be a synchronous encounter, again, the documentation is a little bit different because you can't palpate anything when you're remote, but there are a lot of things that again that you can do, and I think that's where when I went back, whatever institution that you work for or work with, making sure that they're having a playbook and having the local folks, documentation folks, clinical leaders, all collaborating on that to make sure that that all those needs are met.
Right. Any other questions? Dr. Abra has commented that training of medical student, house staff, and fellows has been turned upside down by the pandemic. A challenge for all of us to think carefully about and address, which I agree, but I think we'll find much better way to train them, and they will be much better doctors.
Yeah, I think in some ways we have to, for us, we have to unlearn kind of our hardwiring on how we take care of patients. But I do think it's so. I think for the next generation, they'll have some advantages. But I do think Graham and Dr. Law's and others' comments are really pertinent. We do have to be mindful that there is a lot of value in human touch and face-to-face contact. So I don't want to minimize that either. But I think that's something that we need to figure out.
Great. Thank you so much, Leslie. Looking forward to hear your talk and see you again, hopefully in person soon. But thank you.
Yep. Thank you very much.
So we'll be back